Good afternoon. My name is Ntobe Gondusi, Chair of Medicine at the University of Cape Town, and I'm delighted to be chairing this session on cardiomyopathies. So I'd like to invite our first speaker, Dr. Ahmed Salah, who's going to speak to us on HCM and heart failure. Are there new options?
Thank you very much, Mr. Chairman. Today I'm going to talk about hypertrophic cardiomyopathy and heart failure. Are there new options? As we know, hypertrophic cardiomyopathy is caused by mutations in sarcomeric genes. Approximately 1,400 causative mutations have been identified in 12 sarcomeric genes, of which more than 70% involve the myosin beta heavy chain gene and the cardiac myosin binding protein C gene. Hypertrophic cardiomyopathy is inherited in an autosomal dominant pattern with incomplete penetrance. Almost 0.2% of adults have hypertrophic cardiomyopathy, and 0.029% of children again have hypertrophic cardiomyopathy. Patients with hypertrophic cardiomyopathy can have different types of clinical presentation, natural history, and prognosis. Number one, patients at high risk of sudden death without symptoms of heart failure. Number two, patients with progressive symptoms of heart failure. And number three, patients experiencing atrial fibrillation with high risk of thromboembolism and stroke. Heart failure has become the predominant cause of morbidity and mortality in patients with HUCM, being responsible for as many as 60% of disease-related deaths. Left ventricular outflow tract obstruction is the most frequent cause of decreased exercise tolerance in HUCM and a strong independent predictor of heart failure progression and mortality, fourfold greater than in patients without obstruction. HUCM is essentially an obstructive disease with 70% of patients presenting with a gradient in the LVOT, either at rest or with provocation. Treatment of obstructive HUCM therefore represents a critical step in the management of patients with HUCM, with the potential to significantly impact the mortality and morbidity of this disease. As we know, echocardiography is playing the key role, or the most important method to diagnose and for prognosis of HUCM. We use echocardiography to estimate the thickness of the myocardial muscle and the gradient across the LVOT, gradient of the LVOT. Non-pharmacological treatment of obstructive HUCM, transaortic septal myomectomy is the most effective treatment to abolish the outflow tract gradient and improve long-term quality of life. Septal myomectomy has been shown to be an effective therapy by improving short and long-term symptoms in 90% of patients, allowing longevity no different from that of the general population, and potentially reducing the risk of sudden death with a safety among the best in the field of open heart surgery, 0.5% mortality when performed in experienced centers. The other non-pharmacological option of septal reduction therapy is alcoholic septal ablation, in which septal thickness reduction is achieved through a well-localized myocardial infarction and a subsequent replacement scar. This procedure appears to have the same short-term outcome as septal myomectomy in the term of mortality, but more frequent use of pacemaker implantation for advanced AV block and less extent and stability in reduction of the LVOT gradient. This is a systematic review and meta-analysis showing a comparison between ablation of septal and septal myomectomy, alcohol ablation, and septal myomectomy. As we see here, there is a significant difference in the favor of alcohol ablation in the peri-procedural complication. However, for septal myomectomy, it is better, significantly better in re-interventions, in more pacing dependency, in fall in NIHA class and resolution of angina. So whenever we have a good experience center for surgery, surgery is better. The European Society recommendation, it is recommended that septal therapy, reduction therapy may be performed by experienced operators. Septal reduction therapy to improve symptoms is recommended in patients with a resting or maximum provoked LVOT gradient of equal or more 50 millimeter Hg and are in NIHA class 3 to 4 despite maximum tolerated medical therapy. Septal myomectomy rather than alcohol ablation is recommended in children with an indication for septal reduction therapy, as well as in adult patients with an indication for septal reduction therapy, and other lesions requiring surgical intervention like mitral valve abnormalities. Pharmacological treatment of hypertrophic obstructive cardiomyopathy. Beta blockers is the mainstay treatment of HOCM pharmacologically, and if not tolerated or contraindicated, will come after that calcium channel blocker like verapamil and diltiazem. And if the patient is still symptomatic, we have disopyramide and mavacamten. And we will talk about mavacamten. In every patient with HOCM, we should risk stratify the patient whether he has a risk of atrial fibrillation or ventricular arrhythmia. And if we have atrial fibrillation, rate or rhythm control plus anticoagulation. Anticoagulation is in the presence of atrial fibrillation is mandatory in patients with HOCM. معلش في حاجة بتظهر. لا ما خلصش. السلايد هنرجع بس معاه. بس معايا على الفلاش لو عايز. معايا. I tried with this one. It's not working. It's working now. تمام اشتغل. I'm talking about the pharmacological treatment of hookah. Recently, we have myosin inhibitors. The myosin-actin interaction presents the fundamental unit capable of generating force in the sarcomere. The conformation of the myosin is fundamental in determining the number of interaction sites with actin and therefore the total force that will be developed. In hookah, the excess of active bridges between myosin and actin contributes significantly to the hyperdynamic behavior of the left ventricle and impaired myocardial relaxation. Through inhibition of the myosin ATPase, cardiac myosin inhibitors reduce the number of myosin-actin active sites and potentially reduce the hyperdynamic state of the left ventricle that greatly contributes to generating the outflow tract gradient during systole. Mavacamten, the first clinical study on patients with obstructive hookah was the Explorer Hookah study published in August 2020 in The Lancet. In this study, 251 patients were randomized to mavacamten or placebo and followed up for 30 weeks. Treatment with mavacamten achieved the primary endpoints improvement of cardiopulmonary exercise tolerance or NIHA class improvement in 37% of treated patients compared to 17% of placebo patients. As regards the secondary endpoints, treated patients more frequently showed a reduction in the outflow gradient, less than 30 mm Hg peak, and an improvement in the subjective perception of well-being through the Kansas City Cardiomyopathy Questionnaire Clinical Summary Score. In the Valor Hookah study, 112 patients with a peak LVOT gradient more than 50 mm Hg and NIHA classification 3 and 4, eligible for non-pharmacological septal reduction therapy, were randomized to mavacamten 5 to 15 mg or placebo. The primary endpoint was to assess how many of these patients still met septal reduction therapy eligibility criteria after treatment. After 16 weeks, 76% of patients on placebo remained eligible. However, 17% of patients on mavacamten met the established criteria of septal reduction therapy. Mavacamten was also tested in patients with non-obstructive hookah, with the rationale that this drug, by altering the contractile mechanics of the cardiomyocyte, could have a favorable effect on pathophysiology of the disease and therefore improve symptoms. The Maverick Hookah multi-center trial randomized 59 patients to mavacamten, 2 different doses, and placebo. After 16 weeks of treatment, the drug well tolerated by the patient and significant reduction of NT-proBNP was observed in the treated group. The MAVA LTE study is a 5-year extension that includes 231 of 244 patients who completed phase 3 treatment of the Explorer Hookah trial. The study showed that longer-term treatment of symptomatic hookah with mavacamten has sustained improvement and is well tolerated. Aficamten is a new myosin inhibitor being studied for the use in patients with symptomatic obstructive hookah. It has distinctive features including a shorter half-life than mavacamten, reversibility of drug effect within 24 hours of drug discontinuation, a dose-response ratio that allows for a broad therapeutic window and lack of significant drug-drug interaction. Redwood Hookah randomized 2-to-1 of aficamten, 2 different doses or placebo, with a duration of 10 weeks, showed a reduction of the gradient in LVOT both at baseline and after Valsalva maneuver, and significant reduction of NT-proBNP in the majority of patients. In this study, response in terms of subjective improvement in symptoms was observed in 43% of patients treated with the lowest dose and 64% of patients with the highest dose of the drug. There is no doubt that the use of these drugs can represent an innovative approach in the pharmacological treatment of HOCM by intervening on one of the pathophysiological aspects of the disease, which is contractility. As shown, this is an ECG of a 35-year-old male is complaining from progressive dyspnea. This patient did coronary angiography 2 times, and it was proved that he has normal coronaries. However, by doing echocardiography, by experiencing hands, it was HOCM. It is not. So, as we see this diffuse T-wave inversion all over the ECG is one of the differential diagnoses. HOCM must be excluded. Don't miss to risk stratify patient with HOCM as patient with high risk for sudden cardiac death should put an ICD. Thank you very much.
Thank you very much for that great lecture. May I ask, in Egypt, are there centers that offer both myomectomy as well as alcohol septal ablation?
Yes, I think actually in Cairo University and Shams University, I'm from Suez Canal University. We have also some centers, I think, in other cities. But I myself, recently, we have a colleague. He was internist and he was proved to have HOCM. He just did the operation 2 weeks ago in our hospital in Suez Canal University, septal myomectomy. And he's good. Fantastic. Now. The gradient decreased almost from 60 millimeter HG to 35 millimeter HG.
And is mavacamten available and routinely prescribed?
It is available, but I don't know, is it feasible for patient by the company to, but it is available. I know it is available.
Wonderful. Thank you very much for that fantastic lecture, and congratulations.
Thank you.
So we're now going to go to our next speaker, who is, thank you. So, Dr.
El-Kilani, Professor of Cardiology at Shams University. I'm going to talk about amyloidosis. From diagnosis to amyloid depletion. Okay. ATTR cardiomyopathy from diagnosis to amyloid depletion. This is the shape of amyloid heart. Amyloidosis is a mysterious disease. What is it? Too many stimulants, ApoA, immunoglobulin, lysozyme, TTR, any of these, and actually other 36 proteins, if they are present in excess amount in the circulation, they cause these fibrils to deposit in the myocardium. This is very strange. Too many stimulants with one end stage for all of them. This is very strange. It's characterized by organ deposition of aggregated misfolded protein fragments, 36 known proteins, multiple organ system affection, as we can see here, ocular, cardiovascular, renal, gastrointestinal, musculoskeletal, and nervous. This is the shape of amyloid material with green birefringence, which means double reflection when viewed under the cross-polarized light after staining with Congo red. So this is very characteristic. It can be easily diagnosed. The problem is that you need a biopsy. Do we need to do biopsy for all the patients? We'll see right now. So this is the shape of amyloid material. This is the light red here. So it's deposited in between the myocardial cells. So look what it does. It pushes, infiltrates, and squeezes the myocardium in between the amyloid material. The problem in amyloidosis, especially from the cardiological point of view, that the prevalence of cardiac amyloidosis is directly related to mortality. So if amyloidosis, for example, affects the heart or affects the nerves, if it affects the heart, it gives you more mortality. So the more cardiac involvement, the mortality increases. How is it formed? As we can see here, there are two main types that affect the heart. AL amyloidosis, which is related to blood diseases, and ATTR amyloidosis. We'll see right now what happens. In AL amyloidosis, the bone marrow, we have plasma cell dyscrasia and the plasma cell abnormality, which gives you free light chain. Here, the stimulant is free light chain. The free light chain leads to fibril formation and then deposition in the liver and kidney and heart and so on and so. In ATTR amyloidosis, a different stimulant, which is the transthyretin tetramers. Tetramers means 4, so they are 4 monomers connected together to give you a tetramer. And then it's misfolded and fragmented into monomers, and then it causes you fibril deposition, again the same pathology. So two different stimulants leading to the same outcome. And again, it deposits in many organs. So 98% of cardiac amyloidosis have one of two diagnoses. ATTR cardiomyopathy, A for amyloidosis, TTR for transthyretin protein, which is the precursor of the fibril. And AL, A for amyloidosis and L for the light chain, which is related to the blood disease, the plasma cell disease. The ATTR amyloidosis has two types, wild type, which is the non-mutant type, which is usually related to age, and hereditary type, which is related to gene mutation resulting in amyloidosis. Why is this baby crying? He's crying because the patients with AL amyloidosis are having a difficult journey of diagnosis. The patient starts here, and to reach diagnosis, he moves a lot between many doctors with average 4 physicians for diagnosis. Of course, maybe more. Diagnosis of AL amyloidosis is difficult and convoluted for many patients. And of course, AL amyloidosis means that the patient has a blood disease and the mortality is worse. As we can see here, plasma cell, especially the B lymphocyte, can produce a big amount of free light change, and it has 50 to 70% cardiac involvement. And multiple myeloma has 10% AL amyloidosis, and amyloidosis has 10% multiple myeloma. So we should think of a blood disease. Systemic, mainly kidney, and the prognosis is bad. This is the immunoglobulin structure. This is the heavy chain in blue and the light chain in pink. The light chain, we have two types, kappa and lambda, and we will in a minute say what does this mean. So remember that the kappa and lambda are fragments of the light chain, which is the stimulant for the fibril deposition. Why is it dangerous? Because the mortality is bad. With cardiac AL amyloidosis, with cardiac involvement, the mortality, the lifespan is less than 6 months. So you don't have much time to waste. So if you diagnose AL amyloidosis, send the patient directly for a hematologist to start his work. And this is the first step that you should do for any patient with amyloidosis. First, number 1 is to exclude AL amyloidosis. If he is AL amyloidosis, send him directly for the hematologist, because if you spend too much time diagnosing, send the patient to MRI, take an appointment, and then come back, you will lose the patient during this period. So it's a risky procedure. Once you diagnose, once you have suspicion of amyloidosis, go exclude AL first, and then take your time with the ATTR. The prognosis is not bad. Why is this baby laughing? Because ATTR amyloidosis, the other type, the protein, which is the transthyretin, is produced by the liver. Does it have a normal function in the heart? Yes. It has a function to transport the thyroid hormone and vitamin A. There are two types, wild and mutant type, as we told you before. The senile type, which is the non-mutant type, after 65 years, slowly progressive. Prevalence is underestimated because in postmortem studied, 25% of patients after 80 years has amyloid deposition. And 15% of patients with HFpEF after 80 years have amyloid deposition. 50% of patients have carpal tunnel syndrome, and this is a very important note, 3 to 5 years before cardiac involvement. So if you have a patient that has bilateral carpal tunnel syndrome or spinal stenosis, and his age is old, think of amyloidosis. This might be an early diagnostic sign, okay? It's a close familial type, of course. So what's the pathophysiology? As we said, liver secretes TTR tetramer and then dissolve the four components, dissolved into monomers and then misfolded and then amyloid fibril deposition. Actually, we don't know why does the tetramer convert to monomer. We don't know. Maybe it's thermostability, maybe it's an unfolded transthyretin is not cleared enough, maybe alternation in some protein production, we don't know. But it's related to old age. So the cause is not known. So now we understand the pathology. Let's go for the diagnosis. It can deposit anywhere. So it can give you a lot of presentations. But diversity. That's why they put red flags for diagnosis. What are red flags? The red flags that give you alertness. When you see it, you think of maybe it is the amyloidosis. So, for example, patients with HFpEF, 10 to 13% of patients with HFpEF have amyloidosis. Aortic stenosis, 16% of patients with aortic stenosis has amyloidosis, and arrhythmias and conduction disturbances. So, we should think of it whenever we have one of these red flags. Do we have other red flags? Yes. In history, paresthesia, constipation, carpal tunnel syndrome, as we said, spinal stenosis, glaucoma, neuropathy, cardiomyopathy, physical examination, biceps tendon rupture, weight loss, and so on. So, investigations. Classic, LVH in echo, low voltage in ECG. But it's not a must. Absence of low voltage ECG does not exclude. So, you might have a patient with normal voltage ECG and we don't have diagnosis. Echocardiographic, wall thickness, of course, granular sparkling, pericardial effusion, atrial fibrillation, global intravenous strain, severely reduced, and we have the characteristic sherry on top, and this is the meaning of a sherry on top. But again, absence of sherry on top does not exclude amyloidosis. So it's not a must that you find it. Cardiac magnetic resonance imaging, it has also characteristics, but it does not distinguish AL from ATTR. It will only tell you that there is amyloid material in this heart. That's all. Finally, technetium PYP, which is the pyrophosphate. This is primarily technetium done for the bone scan, but because the microfibrils has minute calcium deposits, so it's attached to the microfibril. That's why it can be detected. These are the microcalcifications, and you can find it and grade it 0, 1, 2, 3. This is not part of our interest, of course. But when AL amyloidosis is ruled out by exclusion of monoclonal gammopathy, and we'll tell you about this in a minute, specificity of scintigraphy of grade 2 or 3 of ATTR cardiomyopathy is 100%. So we don't need a biopsy anymore to diagnose. If you have a patient with suspected amyloidosis, and you go on excluding AL amyloidosis, what's the next step? I will do scintigraphy. If it's positive grade 2 or 3, it's 100% sensitive, that specificity, 100% specific to diagnose ATTR amyloidosis. So, goodbye biopsy. No more. Skin, colon, abdominal fat, cardiac biopsy, these were all lines of diagnosis in the past, and we might need it in some cases. We are not quite sure, but most of the cases can be diagnosed by the technician. So we are confused with too many investigations and choices. What's the sequence? Organize your mind to organize your mind. Number one, AL amyloidosis exclusion, as we said before. Here comes the importance of kappa and lambda. You measure the kappa and lambda in the serum, and they have a ratio with normal values. If it exceeds these normal values, so the plasma cell is secreting too many amount of this, this is the precursor of the amyloid material. Serum protein immunofixation to detect these monoclonal proteins in the serum or in the urine. You have to do the 3 tests. Ruling out AL amyloidosis should be considered as a clinical priority, as we said before, of the high mortality rate of these patients. Okay. And all the C tests should be done. Here is the main diagram we're talking about today. Let's first test for AL amyloidosis. If you find the kappa and lambda and the serum and urine tests are positive, send the patient directly to the hematologist. This is not part of our work. Second step, if you are suspicious, nuclear scintigraphy. If the nuclear scintigraphy is positive, class 2 or 3, you do diagnosis, and then you only do genetic testing to exclude the mutant type of ATTR amyloidosis. So it's simple. Is there help for treatment? Amyloid deposit already present inside the myocardium. What can you do? 3 steps you can work on. Number 1, the TTR protein, you can stop or even slow down the production of TTR protein. It makes sense. Second step, you can stabilize this tetramer so not to be monomer. Yes, this is the second step. And they thought, such a mad idea. Can they dissolve the amyloid material from the myocardium and get it back to the normal structure? This is very strange. Let's see. First of all, of course, it goes without saying that you can simply remove this liver and get him another liver that works normally without giving me too many unstable tetramers, trans 13 tetramer. You can give it, you can give the patient a new liver. So transplantation, of course, a solution, but it's a drastic surgery. Second thing, that you can inhibit production of this tetramer through small interfering RNA, like we do in the PCSK9 modulating protein treatment. Small interfering RNA or antisense oligonucleotide through manipulating the RNA so we stop the production of TTR protein. It's a brilliant idea as well, but take care. This does not affect the amyloid material already deposited. You cannot do this. So the amyloid material, that's why the early diagnosis is extremely important, because you cannot do anything regarding the myocardium already affected, but you stop the further accumulation. Okay, and then the problem is it's IV treatment, so the patient should be hospitalized. Second thing, there is no mortality data. So these drugs does not have any mortality data. Second option, which is the tafamidis, which is available actually in Egypt, but somewhat expensive. It's TTR stabilizers. As we can see here, if you can look here, these 4 monomers are connected through this red connection. The tafamidis stabilizes this connection so it does not disconnect and give you monomers. So the protein stops, which is very good. The process is good. Do they have data? Yes, they have data, which is ATTR ACT trial, which showed 30% relative risk reduction in all-cause mortality, and number needed to treat is 7.5 patients. This is very good. Mortality benefit. Again, 6-minute walk test. So regarding the quality of life, 6-minute walk test improved by 76 meters. And the KCCQ score, which is also related to the quality of life, improved by 14 points in patients who received tafamidis. This is very good. And there is long-term follow-up, 5 years, mortality data, and it showed 41% relative risk reduction. So the patients with cardiac amyloidosis who received the tafamidis are better than the others by 41%. This is very good. A brilliant idea, as I told you in the beginning. They thought of the myocardium as the amyloid material gets in and gets out. So think of the production. You can decrease the production and you can accelerate the clearance of amyloid material, because this process, it happens, but it's very slow. So the production and the accumulation of amyloid material inside the myocardium is extremely more rapid than the clearance. They had too many trials, none of them yet proven. Doxycycline, antibodies against TTR, and antibodies against serum amyloid P component, which might dissolve the amyloid material. Research is still ongoing, no data up till now. So the only approved medication right now is the tafamidis, which is likely it's available in Egypt, but the problem that it is very costly. This is the future, to dissolve the amyloid material. So we still have hope. Thank you very much.
Thank you very much. I'm delighted to hear you've got tafamidis available in Egypt.
Yes,
I just had one comment to make, which is that in the last 3 years, there have been 2 papers from Mariana Fontana's group in London, from the Nightingale Hospital, showing that using a combination of multi-parametric CMR with parametric mapping, both for T1 and ECV, you can now reliably differentiate AL amyloid from TTR amyloid.
Okay, so with sharing data from more than one parameter, this is very good. Yeah. This is very good.
Yeah, but a really, really excellent overview. Thank you.
Thank you very much.
Thank you so much. So next, I'd like to invite Dr. Askalani, who's going to speak to us about diabetic cardiomyopathy and heart failure.
Thank you, Mr. Chairman. My talk will be about diabetic cardiomyopathy and heart failure, new target for therapy. Later.
The next, the backward.
Okay.
The later.
I have introduction, clinical symptoms and diagnosis, pathogenetic mechanisms of diabetic cardiomyopathy, and therapeutic intervention. Here, DCM is diabetic cardiomyopathy, not dilated cardiomyopathy, okay? In UKBDS trial, it is a mega trial in diabetes. It was found that for hemoglobin A1C less than 6%, there occurred 2.3 heart failure event for 100 person per year. For hemoglobin A1C more than 10%, it reached about 12 heart failure event for every 100 person per year. Prevalence of heart failure in general population is about 1 to 4%, but in diabetic population it reached 15%. So diabetes is a major problem for cardiomyopathy or for heart failure. With the growth of the economy, changes in lifestyles and diets, and the aging of population, the number of diabetic patients and disease incidence are increasing at an alarming rate. According to statistics, by the 2021, there was 537 million people with diabetes mellitus. And by the 2045, they will reach 784 million diabetic patients. Diabetic cardiomyopathy was first introduced by Rulber in 1972. Is a common and severe complication of diabetes that can lead to the development of heart failure. Diabetic cardiomyopathy, which is the dominant cause of heart failure in patients with diabetes, it is very important to know that it is caused by abnormal glucose metabolism, resulting in structural heart defect and dysfunction without other cardiac risk factors. no coronary artery disease, no hypertension, and severe valvular disease. So it occurred due to abnormal glucose metabolism. At present, although there are therapeutic strategies available to treat diabetic cardiomyopathy, treatment is mainly focused in controlling blood glucose and blood lipid. This is the main cornerstone for treatment of diabetic cardiomyopathy, is to control blood glucose and blood lipid. And there is a lack of effective drugs or strategies targeting damaged myocardial tissue. Therefore, understanding the clinical symptoms, identifying early and highly sensitive diagnostic biomarkers, knowing the underlying pathogenetic mechanisms, and developing new targeted intervention for diabetic cardiomyopathy are critical for improving the prognosis of patient and preventing the occurrence and development of this disease. Clinical symptoms and diagnosis of diabetic cardiomyopathy. As I mentioned, that diabetes mellitus induced pathophysiological condition in which cardiac dysfunction and heart failure occurred in the absence of coronary artery disease, no hypertension, and other valvular heart disease. The initial symptoms of diabetic cardiomyopathy, the patient will present with mild left ventricular stiffness, followed by decreased compliance and diastolic dysfunction, which are easily ignored by patient, thus missing the best opportunity for the early diagnosis and treatment. The subsequent clinical manifestation will be arrhythmia, angina equivalent, and finally development of congestive heart failure. So, diastolic dysfunction in a diabetic patient, we have don't to myth the symptoms of the patient if he has dyspnea, and if by it we have diastolic dysfunction. It can progress to diabetic cardiomyopathy. At present, many non-invasive techniques, including ECG, echo, chest X-ray, pulsed wave Doppler tissue imaging, and MRI, all can use as a non-invasive technique. But endocardial biopsy have been used to detect changes in the cardiac architecture and function. Endocardial biopsy, which is the gold standard for the clinical diagnosis of diabetic cardiomyopathy, can detect cardiac hypertrophy, necrosis, myocardial fibrosis, and other pathological changes. But this method cannot show the abnormal diastolic function of the heart in the early subclinical stage and is associated with a certain degree of trauma. So it is very important to detect the early subclinical stage, which is diastolic dysfunction in a diabetic patient without ischemic heart disease, without coronary artery disease, without hypertension, without valvular heart disease. Also, there are many diagnostic markers and inflammatory mediators can be used at early diagnosis and treatment of diabetic cardiomyopathy. Increase serum hemoglobin A1C and cardiac troponin level, increase in atrial natriuretic peptide and brain natriuretic peptide also can be used, as well as the increase in calcium sensitive receptors in cardiomyocytes and the restoration of calcium hemostasis in type 2 diabetic cardiomyopathy. NT-proBNP is significantly increased in diabetic cardiomyopathy and can be used also. The detection of serum markers, increased inflammatory mediators, elevated fibrotic markers, and new novel markers such as galactine-3 and adiponectin are significantly changed in the clinical course of diabetic cardiomyopathy stage. Also, decreased antioxidant markers can also provide a base for the early diagnosis and treatment of diabetic cardiomyopathy. So, many mediators, many biomarkers, many inflammatory markers can be used to diagnose diabetic cardiomyopathy. What is the pathogenetic mechanism of diabetic cardiomyopathy? The pathogenetic mechanism of diabetic cardiomyopathy are interact and are still not fully understood. Chronic hyperglycemia is the main corner. Chronic hyperglycemia is the main cause for patient to develop diabetic cardiomyopathy. It causes toxic effect on the myocardium during the progression of diabetic cardiomyopathy through direct and indirect pathways, including cardiac remodeling, diastolic and systolic dysfunction, and finally severe heart failure. This is what happened in hyperglycemia, as we say. Hyperglycemia causes increased hyperinsulinemia and insulin resistance. By many steps, lead to increased cardiac energy metabolism, increase the cardiomyocyte apoptosis, increase the myocardial fibrosis, finally diabetic cardiomyopathy. So hyperglycemia in diabetic patient is the main cause for inducing diabetic cardiomyopathy. Persistent hyperglycemia, as we see here on the cellular or molecular base, finally result in diabetic cardiomyopathy. So the process starts by abnormal glucose metabolism and insulin resistance, persistent hyperglycemia and glucotoxicity in diabetic cardiomyopathy, increase the formation of EGA in myocardial cell, which cross-link with extracellular matrix protein, resulting in increased cardiac fibrosis and impaired myocardial diastole. Cardiomyocyte apoptosis. The cardiomyocyte injury and abnormal apoptosis may occur in the early stage of diabetic cardiomyopathy and are directly related to myocardial hypertrophy and heart failure. Myocardial fibrosis is one of the main histological manifestations of diabetic cardiomyopathy and increase the stiffness of the myocardium, reduce cardiac diastolic function, cause systolic dysfunction, and finally induce sudden death. So, the therapeutic intervention in diabetic cardiomyopathy, first of all, to control diabetes. First of all, to reduce the incidence of hyperglycemia. This is the main cornerstone. As we have in heart failure, we have 4 pillars: ARNI, MRA, beta blocker, and SGLT2 inhibitors. Here, focusing for control diabetes first. Metformin treatment has a low risk of mortality in diabetic patient with heart failure compared with sulfonylurea or insulin. Metformin, which is first-line anti-diabetic drug, improving diabetic cardiomyopathy by regulating glycolipid metabolism, reducing EGE regeneration, and improving mitochondrial function, resulting in cardioprotective effect. So, metformin could be used, yes. What else? Sulfonylurea, which stimulate alt beta cells to release insulin without affecting the senses of patient insulin. This class of drugs is limited to patient whose alt beta cell function remain intact and has no effect on patient whose alt beta cell function is impaired. So we can use metformin to control hyperglycemia, sulfonylurea. Also, the new generation of oral anti-diabetic drugs like GLP-1 receptor agonists, such as liraglutide and semaglutide, can enhance myocardial sensitivity. To insulin, improve the glucose uptake rate, promote myocardial energy metabolism, and inhibit cardiomyocyte apoptosis, which contribute to the treatment of diabetic cardiomyopathy. So we have drugs to treat diabetes. They have a cardioprotection effect. This is very important. When you are selecting a treatment or a drug to control diabetes for a patient, it is better to have a drug that you have cardioprotection for the patient. Like in hypertension, what is beyond blood pressure control? We are seeking about a drug to have a protection for the heart, for the kidney, the same in diabetes. DPP-4 inhibitors such as linagliptin, sitagliptin, and saxagliptin can prevent cardiac dysfunction, but saxagliptin was associated with unexpected increased risk of hospitalization for heart failure. So if you will use DPP-4 inhibitors in a cardiac patient or even not in a cardiac patient, in healthy one without heart failure, don't use saxagliptin. SGLT2 inhibitor, sodium glucose cotransporter type 2 inhibitor, which are another class of oral glucose lowering agent that prevent the reabsorption of glucose, can significantly affect cardiac function, providing a new and promising therapeutic option for diabetic cardiomyopathy. As we know now, SGLT2 inhibitor, one of the 4 pillars in treatment of heart failure, because they have a cardioprotective effect on the heart regarding treatment of diabetes. Insulin also has a cardioprotective effect on cardiomyocytes. In addition to glycemic control, there are a variety of drugs that have been shown to have effect on the heart on diabetic cardiomyopathy. Number 1, statin. Statin improve left ventricular function and inhibit myocardial fibrosis to prevent diabetic cardiomyopathy. But take care for that. Lipophilic statin can increase blood glucose level and exacerbates the severity of diabetes, which suggests that the change in blood glucose should be monitored in patients with diabetic cardiomyopathy during the clinical use of lipophilic statin. RAS blocker, spironolactone, beta receptor antagonist, all this can be used in treatment of diabetic cardiomyopathy like heart failure or dilated cardiomyopathy or ischemic cardiomyopathy. Finally, drugs in completed and ongoing clinical trial. There are many drugs like caficrestate, trimetazidine, alpha-linoic acid, empagliflozin, dapagliflozin, and tadalafil. Also, there are new potential intervention strategies: vaspin, melatonin, coenzyme Q, messenger RNA, circulating RNA, and stem cell transplantation. And finally, very important, is lifestyle intervention for this patient to prevent diabetic cardiomyopathy or even after developing diabetic cardiomyopathy by healthy diet and proper exercise. Thank you very much.
Thank you very much for that very informative talk. So you showed us a whole host of drugs that are used to treat diabetes that will retard progression and development of diabetic cardiomyopathy. But are there any studies that actually demonstrate efficacy of an agent in treating or reversing diabetic cardiomyopathy once it's developed?
For statin? Excuse me, for statin or what?
No, I'm asking in patients who have diabetic cardiomyopathy, are there drugs that are shown to actually treat it and make it go away once it's developed? So the drugs you showed us really showed the importance of prevention and its development.
I don't understand. What do you mean?
So the question I'm asking is there any evidence to show that once somebody has developed a diabetic cardiomyopathy, by instituting drug therapy, you can actually reverse the process?
You ask about if there is any drug to prevent the diabetic cardiomyopathy?
To treat it once it's developed.
Improvement for the diabetic cardiomyopathy? Yes, the routine drugs, first of all, control hyperglycemia very well. After that, using statin and the other treatment for heart failure or for cardiomyopathy, RAS blocker, beta blocker.
So all of those are for prevention, but I'm saying once it's developed.
Once it's developed, yes.
Is there a way to cause regression using drug therapy?
I don't know if there is a drug to regress that or not.
Okay. Thanks. And one comment, it's not in routine clinical use, but there's now quite strong evidence that if you are not certain whether somebody has diabetic cardiomyopathy or not, if you do magnetic resonance spectroscopy,
yes,
you can actually have a very specific or pathognomonic signature with impairment in cardiac energetics that definitely confirms the diagnosis of diabetic cardiomyopathy.
Magnetic resonance?
Spectroscopy.
Okay.
Yeah. There's one final question over there.
لو في اي حاجه يعني ممكن تحسن، هو في اوريدي ستاديز كانت معموله كده، بس هي اوريدي كانت ثيسيس بس ما لم ترقى اللي هي تبقى ستادي لسه، اللي هو كان بيشنت بيبقوا بروفد اللي هم عندهم دايابيتيك كارديوميوباثي بسبيكل تراكنج امبيرد، برغم ان هو الفانكشن كانت نورمال وبياخدوا امباجليفلوزين او داباجليفلوزين كده يفولو اب لسبيكل تراكنج.
Yes. Yeah. For the role of DABA or empagliflozin to improve the diastolic function in speckle tracking in patient systolic function. Diastolic function, he has normal systolic function, but impaired diastolic function. Normal systolic function by routine echo. Yes, and by speckle tracking it is impaired.
بالظبط كده.
Yes, we have to start dapagliflozin or empagliflozin. The same that happen in patient with on chemotherapy and radiotherapy. That's it. We have normal systolic function by 2D echo and M mode, but by speckle tracking it is impaired. So you have to start the treatment even with this normal systolic function by 2D. Yes. Okay.
Wonderful. Thank you very much.
Thank you.
Congratulations. The final lecture on ischemic LV dysfunction is by Dr. Wael Hasib.
Not here.
It looks like it's not here. Are there any other questions for all three of our speakers?
Amyloidosis. Colchicine, amyloidosis.
I don't have, the question is about the use of colchicine in amyloidosis. To my mind, I don't think there is any data about colchicine in amyloidosis. So,
الله اعلم بقى المعلومه بس انا
know that.
ما لقيتهاش.
Know that. Know that.
Can I have a patient with cardiac amyloidosis that have the 2 times AL and 3TR?
At the same time, I don't know. Can? Theoretically, he's very unlucky, of course, to have the two diseases together. Maybe he's old and he has ATTR amyloidosis, and at the same time he has a blood disease. It might happen. Of course, yes. By treating, you're not treating amyloidosis at that time. You're treating the blood disease so as to decrease mortality for the patient to live to treat ATTR. So this is the idea. Okay, thank you.
Well, it's a pleasure to bring the session to a close, and thanks to our speakers.
Thank you very much.